Hi, and welcome to Hughes Knows Nursing, and I am Veronica Hughes, and today we are going to talk about heart failure. So, heart failure can be a little confusing. The anatomy can get a little bit complicated, and then knowing right versus left, and then do we have reduced ejection fraction or not, or is it diastolic or systolic or whatever. So, we're going to talk about it. So, no need to stress. We're going to pick it apart, and it's going to make so much more sense. So let's first talk about how the heart works. So you have veins, and they bring the blood back to the heart. Okay? Now, from the right side of the heart, you're going to then send your blood to your lungs to get some oxygen, and then it's going to go back to the left side of the heart, and then it's going to go to the rest of the body. So this is how it should work, okay? Heart failure, you can have problems in all parts of these different areas. So the left side of the heart pumping out, the oxygenated blood, that's measured as cardiac output. So cardiac output is a term that you need to know. It's just how much oxygen-rich blood is getting out to the rest of the body. So the problem with heart failure is that the heart is unable to contract effectively, or it's not filling properly. So it can't squeeze like it needs to, or it can't fill up like it should. And that causes a decrease in cardiac output, which means that everything else suffers. You're not getting oxygenated, you're not able to meet your metabolic needs, and then the heart can't do its actual whole job. So there are risk factors that put somebody at a higher propensity for this kind of problem. Just age, naturally. Your heart gets tired after it's been pumping for a little while. One time I took care of a guy who was 106, and he was there for heart failure, and I was like, yeah, you're 106. Of course, you have heart failure. Your heart's been beaten for a little while. So, arrhythmias. So AFib is a really common one that can have problems because if your atria are doing this, they're not relaxing and filling like they should, right? Tachycardia, also, if your heart's just beating so fast, there's no time to fill because you're just contracting, okay? Cardiomyopathy can put somebody at risk. Infections such as sepsis or endocarditis or rheumatic fever, we don't see that one as much anymore, but can all put you at risk for heart failure. Drug use, your heart really hates meth, your heart really hates cocaine. Both are very bad for it. Hypertension. So just think about your heart having to push against a high pressure system. So instead of having like a water hose attached to it, right, you have like a juice box straw. So you're just having to work that much harder to get the blood where it needs to go. Coronary artery disease, that paired with myocardial infarction. So you're narrowing those blood vessels. Also with myocardial infarction, you are injuring the walls of the heart. And so when you have injury or death of tissue in the heart, it can't conduct electricity like it needs to. And so it won't move like it needs to. It won't receive the electricity to be able to move blood where it needs to go. Valve disease can also cause a problem. So if the valves inside or going into or out of the heart are not doing their jobs like they should, you can have leakage. You can also not get good pump forward, which can cause the heart to fail because it has to work harder to overcome these obstacles. All right, left-sided heart failure, also known as low output heart failure. So remember, your left side of your heart is the main part of the heart that's pumping blood to the rest of the body. It is the most common cause of heart failure. You will have a decreased cardiac output. So either the left ventricle can't empty, so it's not pumping like as fully as it needs to during systole, which is systolic heart failure, or it's not filling like it needs to during diastole. That's diastolic failure. So to recap, systolic failure, is when I can't pump like I need to. So I'm not emptying my heart out like I need to when I do contract. And diastolic is I'm not relaxing enough to fill up. So when these problems happen, you get a backup into the left atrium. Things that can cause this left-sided heart failure: myocardial infarction, coronary artery disease, and hypertension. The main culprits. So either you can't pump out or you can't contract like you need to. Okay? And then all of the tissues downstream from the heart, which is everything, have decreased perfusion. So they're not going to work like they should. So think your brain, think your kidneys, all of it. So, yeah, you don't want decreased perfusion to anything. Okay, so systolic heart failure, you will also see it written like this: HFREF. Heart failure with reduced ejection fraction. Okay, so like we talked about systolic, it's that squeezing phase of the heart, the contracting phase of the heart. We use the ejection fraction to help us calculate and diagnose the ability of that left ventricle to contract like it should. A normal ejection fraction is greater than 50%. So if you are well and healthy and your heart's doing what it should, greater than 50%. We get that ejection fraction number from a variety of different ways. An echocardiogram can give us that information, or a heart echo. A heart catheterization can give you that information as well. A nuclear stress test can also give you the ejection fraction. So what that 50% number means that 50% of the blood that filled the ventricle was pumped out. So it's not 100%, you're not completely emptying, but half of what gets filled in there should be on its way out, half or greater, okay? Anything that is under 40% is the definition of heart failure with reduced ejection fraction. So, if you see HFREF, it's just systolic heart failure. That means that ejection fraction is going down. You're not getting cardiac output out like you should. All right, let's talk about diastolic heart failure. So in diastolic heart failure, that is HFPEF. Heart failure with preserved ejection fraction. Okay, so with diastolic failure, it's the inability of the left ventricle to relax so it can fill. So it stays kind of tight instead of relaxing so it can fill up with blood like it needs to. Okay, so remember, diastole is that filling, resting phase of the heart. The left ventricle in this case is either too stiff to fill with blood, but it contracts. So the contracting is not the problem, it's just it can't relax to fill up. So you just don't have as much volume in there. So your ejection fraction is actually normal. The percentage of blood is normal, but you don't have enough in there to have good perfusion, okay? There's no issue with pumping or contracting. The primary cause here is hypertension. So your heart is having to work so hard against that high pressure system from your hypertension that you're causing a thickening of the walls of that heart, okay? Signs and symptoms of left-sided heart failure. So you got to think about left lung. So it's going to be respiratory symptoms. So the blood that backs up from the left ventricle into the left atrium is eventually going to make its way into the lungs. So pulmonary edema. Pulmonary edema is like hallmark, bad, scary, that we're most worried about because it is the complication of heart failure that's going to be the most problematic for your patient, because turns out if you have pulmonary edema or fluid filling your lungs, you can't breathe. So good oxygen exchange is not happening, and that's bad for everybody. When you listen to their lungs, you're going to hear rales or crackles, not rhonchi or wheezes, because we're listening and we're hearing fluid. So crackles and rales. Sputum, this is a big one. It's not like your COPD green sputum here. It's pink and frothy because it's blood tinged. Okay, so pink frothy sputum. They're going to be dyspneic, so short of breath. And then depending on their position, like if they lay back, that can also make them feel short of breath, so orthopnea. Typically, there's no chest pain associated with this kind of heart failure unless you have a coronary artery disease happening on top of it. So you have some kind of coronary artery disease where those coronary arteries are blocked. So you're setting up myocardial infarction, right? Heart attack. Then you can have chest pain, but the heart failure itself doesn't necessarily cause chest pain. You will hear an S3 gallop, which is a heart sound that's not normal. So normally you hear S1 and S2. You add that S3 sound whenever you have left-sided heart failure. You're going to have signs of organ failure. For example, we already talked about the kidneys a little bit. They're not getting perfused like they should. So you're going to have decreased urine output. So one of the best measures of good cardiac output is urine output. So if you have a decreased urine output, you got to think, is it my kidneys that are broken, or maybe my heart's not perfusing like it needs to, perfusing the rest of the body like it needs to. There is a little acronym that you can use to help you remember all of these. It's called DO-CHAP. All right, I'm going to write it out for you. DO-CHAP. DO-CHAP. Dyspnea, D. Orthopnea, O. C. Cough. H. Hemoptysis. A. Adventitious sounds. So remember, you're going to hear crackles and rails, not rhonking and wheezes. And P is pulmonary congestion. So DO, CHAP, C-H-A-P. All right, that's all we have for left-sided heart failure for now. In the next video, we're going to talk about right-sided heart failure.